A 66-year-old male patient presented in the OPD with pain in the upper abdomen since 5 years. Since last 10 days, the pain was severe in nature, and he had episodes of pain in the past 5 years. Since last 10 days, he used to get pain every twice daily, which was episodic in nature, and he used to vomit during the pain. The pain was coming on taking food, and was relieved when he was empty stomach. Patient also had was hypertensive since last 10 years, and he was on Telma 40 milligrams OD. He also gave history of TURP 3 months back in a outside hospital. On examination, abdomen was soft, and tenderness was noted in the right hypochondrium. No organomegaly. USG investigations. USG revealed 6 stones in the lumen of the gallbladder. In view of the cholelithiasis, symptomatic cholelithiasis, patient was taken for laparoscopic cholecystectomy. Under general anesthesia, 10 subumbilical port was introduced by open method. 10 epigastric port was introduced midway between the umbilicus and the xiphisternum. 10 port. Two 5 ports were introduced, one in the midclavicular line and another one in the anterior axillary line below the costal margin. Camera was introduced, and it was noticed that in the calotte triangle, fat was accumulated, which was dissected meticulously, and skeletonization of the cystic artery and the cystic duct were done. The small oozes were controlled by using gauze pieces. The length of the gauze piece should be less than the length of the reducer. The wet gauze pieces are very helpful in controlling the oozing. The dissection was done on the medial and lateral side of the cystic duct. The cystic artery was skeletonized. Lymph node in the calotte triangle was also dissected. Small oozing which was present was controlled by using gauze pieces. 2 clips were applied towards the patient side. 1 clip was applied towards the specimen side. The cystic duct was cut distal to the second clip. The cystic artery was coagulated with monopolar cautery and cut. The cystic duct was cut distal to the second clip. Gallbladder was dissected from the bed of the liver. While dissecting the gallbladder from the liver bed, spillage of bile happened because of loosening of the clip to on the specimen side on the specimen. For this, normal saline wash was given, suction irrigation was done. A Romo drain was introduced in the subhepatic space. Through the anterior axillary line trocar. The 3 gauze pieces which were used to control the oozing were removed. The specimen was also removed through the epigastric port. The specimen was removed. All the trocars were removed. Closure was done. In view of the difficult intubation, the patient was shifted to the ICU and the extubation was done on the next day morning. After extubation, the patient maintained his saturation, was conscious, and was shifted to the ward. Patient is recovering well in the post-operative period. Thank you. Last time.